Welcome to Dental Education Laboratory's online course, Broken File Retrieval by myself, Steve Buchanan, and Yoshi Terauchi. Yoshi Terauchi is the world's greatest expert on retrieving separated instruments from root canals, and this course shares the methods and tools he uses to achieve removal of virtually every broken file he has encountered in practice. That's a fairly bold statement, but I'm witness to the effectiveness of his file retrieval techniques, as I used to rarely attempt removal of broken files. Now that I've been trained by Yoshi, I feel confident, and although I'm not the master that Yoshi is, I'm now able to remove the great majority of separated instruments out of root canals in my patients. First, let me list the course outline. There are 6 chapters. First, Rationale for Retrieval. When is it necessary to retrieve a broken file? When can we leave the file segment in place? It's really important to know the difference. The second chapter is File Breakology, or the study of how files come apart during their use. Obviously, the easiest method of dealing with separated files is to avoid the file failure in the first place. Third chapter, Analysis of Retrieval Difficulty. As we get better at understanding situational retrieval difficulties, we become more successful in our retrieval efforts. Chapter 4, Retrieval Tools. Tools make the dentist, so I will describe the latest advances in microtooling and how this can help us remove broken files. 5, Terauchi File Retrieval Technique. I'm going to share the concepts and methods Yoshi uses in his own practice that is specialized to file retrieval. Number 6, Difficult Cases. We will see exactly how Yoshi manages the most difficult of cases, including how to retrieve files totally beyond the end of the root canal. So let's get into it. Not all broken files should be retrieved, so let's explore the rationale for leaving a broken file in a patient's tooth. First off, the closer the root canal preparation is to the terminus at the time of instrument fracture, the better the prognosis will be if the instrument is retained. Files come apart after they're fatigued and forced to work in the tightest, most curved parts of root canals, so separation often occurs as the file nears the end of the canal. A great number of these will act as root canal fillings and will not need to be retrieved. 4 situations where retrieval is not necessary. 1, when the tooth is asymptomatic with no lesions. 2, when the file is broken short of length in vital cases. 3, when treatment can be completed without retrieval. 4, when broken at length after negotiation. It would be rare that a broken file segment acted as a nidus for infection. File segments are not infectious in and of themselves. Usually, if the root canal has been treated to its full apical and lateral extents, a piece of file left in the periapical tissues will not impede healing. The 6-month recall of this case shows apical healing in spite of the retained instrument in the bone. Here's another case showing excellent osseous healing around a separated file segment in the periapical tissues. The pre-op radiograph shows a broken file beyond the end of the root of tooth number 9. Retreatment of number 9 with MTA brought apical healing in spite of the retained instrument in the bone. When broken files are left in the canal, it's absolutely critical that patients be informed of the occurrence, and the case must be recalled once or twice in the year to follow to be certain of the positive outcome or to see a continuing problem that requires further treatment. Sometimes file segments can be bypassed rather than retrieved. The situations when this is most likely to work are when the file fragments are tiny, when there are confluent canals through which treatment can be accomplished, and when canals are oval, as this leaves a bit more space to traverse around the broken segment. File segments in curved canal regions act as impediments to apical progress along the file path, encouraging bypassing instruments to engage dentin on the outside of the canal curvature, cutting a ledge there, or perforating the root canal. Even when broken files and curved canals can be bypassed, the resulting canal path will usually be straightened or transported. As soon as the broken file has been removed, it opens the original canal pathway, thus lessening the chances of ledging, perforation, or transportation. In this study by Peter Spilly and co-workers, published in the JOE in 2005, they found that teeth with pre-op lesions were significantly less likely to heal than those without a lesion. This is pretty logical. And there's Panavitsai and crew showing that the healing rate for retained instruments was significantly lower in the presence of preoperative periapical periodontitis. That was published in the JOE in 2010. Broken files in infected canals with PA lesions, especially those short of length, need to be retrieved for the case to have a predictable outcome. Broken files that extend beyond the terminus in infected canals require retrieval. Finally, broken files that prevent adequate obturation in necrotic cases that have a lot of accessory anatomy must be retrieved to allow complete root canal therapy to full apical and lateral extents of the root canal system. Files should not be retrieved when file segments cannot be seen, thin roots could be perforated, structural integrity would be compromised, or the case is beyond your current clinical skill levels. Know thy own skills. In addition to all this, remember that canal enlargement to 40% of root width was reported to increase vertical root fracture. So we do need to pay attention to the structural integrity issues. Let's look at the statistics from multiple studies on instrument retrieval. Retrieval time was between 3 and 60 minutes. The success rates were 80%, and the success rate drops after 45 minutes of broken file retrieval attempts. While I disagree that surgical file retrieval is the last resort, conventional file retrieval causes much less post-op discomfort. Also, surgical removal of broken files will often require severe shortening of root structure unless broken files are located in the apical 3 millimeters. Chemical removal takes too much time to dissolve the entire instrument. Some of you out there may not realize that a nickel titanium file put in a test tube like this with sodium hypochlorite will dissolve to a bunch of black goo within about 4 hours. So we really don't want to use hypochlorite during nickel titanium instrumentation, although certainly your files should not get 4 hours of use before you move on. You hear talk about electrochemical removal also, but it's basically the same as the chemical method. But the big problem is the instrument surface in contact with the fluid is severely limited to the coronal end, and it would take days. The intriguing part of chemical removal is that we could dissolve the entire instrument and have no dentin sacrifice required. The mechanical method is the best and most efficient in broken file removal. Mechanical methods include microburrs, microultrasonics, lasso devices, and microforceps.